My name is Melody from California cohort 39. A nursing situation I encountered this week was with a post-kidney transplant patient. He had a living unrelated kidney transplant 5 days post-op with anuria and hematuria. The patient had a medical history of end-stage renal disease, hypertension, and type 2 diabetes. His nephrologist was concerned about organ rejection and ordered a 5-day infusion for thymoglobulin for immunosuppression. The patient already had one infusion completed the night before my shift. He also received dialysis that morning and had a net output of 2,500 ml. His BP ran high in the 160s over 90s, but heart rate, respiratory, pulse ox, and temp was within normal limits. The patient took carvedilol at 9 a.m. and then his doctor added amlodipine at 12. When I took his afternoon vitals, the BP stayed the same at 160s. I told my preceptor I was concerned about the ineffectiveness of the antihypertensives and wondered if the hypertension could be part of the reason for the new kidneys dysfunction. My preceptor agreed that the BP needs to be lowered and made a call to the attending. We obtained a one-time order for another dose of amlodipine. By the time I noticed the situation, it was early in the afternoon, and I had gotten to know the patient and his spouse from our conversations throughout the day. They were cooperative, friendly, and patient with me as a nursing student. I have not had previous experiences with post-transplant patients, but I have had hypertensive patients before that needed to have around-the-clock blood pressure medication and diuretics. Since hypertension and diabetes are risk factors for organ damage, it was important to me to make sure his blood pressure and blood sugar were both controlled as a post-transplant patient. My role as a nurse in this situation was to facilitate the patient's post-transplant recovery by monitoring his vitals, INOs, labs such as CBC, CMP, and kidney functions, and whether the patient is responding to interventions such as thymoglobulin therapy. His AM blood pressure was 160 over 89. The second blood pressure was 157 over 87, which was worrisome because he had gotten a dose of carvedilol prior to that. The attending ordered an additional amlodipine, which was given shortly after the second set of vitals. I started to get concerned when his blood pressure was 167 over 87 when I checked his third set of vitals 4 hours later. I noticed that the patient was having a very difficult time urinating because either nothing would come out or his urine was bright red. I also noticed his feet were swollen but non-pitting, but I didn't realize his hands were swollen until his wife mentioned that his arms looked differently from normal. After spending more time with the patient, I started to think about whether there were other things that could be affecting his blood pressure. I thought about the patient's edematous extremities and related it to his very low output throughout the day. As fluid builds up in a person's body, it could also elevate their blood pressure. This situation reminded me to factor in normal side effects that could change a patient's current status. I started to research the side effects of the medications he was taking and found that thymoglobulin had a common side effect of hypertension. Yes, it was important to control the patient's hypertension, but I forgot to factor in the hypertensive effects from thymoglobulin therapy and fluid retention. What other information did you decide you needed as you considered this situation? As I started to realize that multiple factors could cause the patient's blood pressure to be elevated, I researched the side effects of his medication. I also looked at his INO, and his intake increased as the day went on without any output, so it made sense why his blood pressure didn't decrease after medication. What did your observations and data interpretation lead you to believe? How did they support your response to the situation? After reviewing the patient's third set of vitals, I realized it would have been more troubling if the BP increased. But since the systolic BP stayed consistently around 160s, I knew that it was from the fluid retention and thymoglobulin therapy that caused the elevated blood pressure. It was still important to control the patient's blood pressure, but the overlying concern was to resolve the organ rejection. The patient would need to complete more days of the thymoglobulin therapy to see if it resolved. My nursing intervention towards the situation was to obtain another order of antihypertensives because the order we had was only for once a day. My response was to investigate and learn what other causes could possibly affect the elevated blood pressure. Describe stresses you experienced as you responded to the patient. After obtaining a one-time order for the amlodipine, we had to wait for the pharmacy to send up the medication. The only stress was going back and forth to the tube to see if the medication was finally sent, and having the family continually ask about the medication.